Let's jump into chapter 14, which is sensory function. This kind of goes with the neurosystem, and so you'll see some commonalities in there. But our senses help us to make sense of the world around us, right? Sight, smell, sound, taste, and touch. And so when things go wrong, it changes our ability or our client's ability to react to things, possibly putting them in danger. If someone can't hear a fire alarm, they may not know to get out of the building. Or if they can't feel, as in neuropathy, they may burn themselves with bath water. So let's jump in here. Pain is the most common reason our clients seek treatment. And while this picture reviews more types of pain than the book, we're going to quickly go through them. Pain, remember, is subjective. Pain is what the client says whenever they say it is. And our clients are going to talk or categorize their pain in 3 different ways: by perception. Is it somatic in the skin, muscles, or joints, or does it feel visceral, like from the organs? They can describe it from the duration. Is it acute pain? Is it now, or is it short term, or is it chronic pain that lasts over 6 months? And then they might talk about its characteristics, that it radiates, that it's referred, that it's neuropathic. Pain first travels from its site of attack to the brain via neurons. And so it's the first order neurons that detect the painful stimuli, which then travels to the dorsal horn. And think of this as where all the synaptic connections converge. Okay, so it receives the information and then transmits that to the brain. It's like the relay station, like kind of passing the baton in like a relay. That's how I think of it. Then the second order neurons send the pain signal to the brain. Phantom pain occurs after a body part's removed. However, the client still feels that pain. And this results from severed neurons spontaneously still firing. The good thing is eventually this will resolve. We do have kind of some expected findings as we age that change our sensory system. So unfortunately, our eyes do change as we age. I haven't hit the stage of glasses yet, but I'm sure I'm close. Tear production is reduced, the cornea thickens and is less sensitive, causing blurry vision and an inability to detect eye injury. Reaction time slows with decreased pupil size. Presbyopia, or the inability to see close up, is the most common problem. So typically, we'll see clients holding things farther away that allows their eyes to focus better. The lens yellows, becomes less flexible, which make it difficult to drive at night. And then there's an increased risk of glaucoma, or increased pressure in the eye, macular degeneration, and cataracts. Conjunctivitis, or pink eye, is a common childhood illness. If you have kids or nieces or nephews or anybody, you have likely dealt with this. I have several times with my daughter. Most causes are viral, following an upper respiratory infection, or at the same time. So again, viral is the most common for kids, and it comes with red and watery eyes, maybe some discharge, and feels like there's sand or something gritty in the eye. It typically will start with one eye and can easily move to the other. Bacterial conjunctivitis is most common in those with contacts. It's usually bilateral when it's bacterial with thick discharge. Most times, again, with a virus, it just needs to run its course, but with that cold. But many providers will treat with eye drops, some kind of antibiotic eye drops, because of the risk of complications. Ear infections, otitis media. Let's talk about the difference between otitis media and otitis externa. Otitis media is inflammation in the middle ear, and again, this is super common with kids. It will usually follow or be in conjunction with an upper respiratory infection, just like pink eye. My kid dealt with this pink eye, cold, and ear infections when she was little. The kid may present with ear pain, maybe mild hearing deficit, and then rubbing or pulling at their ears with otitis media. They could have poor feeding if they're in that infant stage. Otitis externa is an infection or inflammation of the external ear canal. We also know this as swimmer's ear. This can also happen when we put Q-tips in our ears and scratch inside unknowingly. This one will typically hurt when the client pulls or pushes their ear, maybe have drainage as well. So what can we do for our clients with any type of impairment with their vision, right? We need to adapt as they're in our care, and then they can adapt as home as well. We don't want to assume that they aren't independent, as many have been living with like legal blindness or total blindness for years. So first we explain and orient them to the environment. Your bedside table is here on your left, your call light's here next to you on the right, the bathroom is here, etc. At times I used to put a piece of tape on the call button, so that they could feel it. And we want them to know how to call us. We can help them adapt to these things at home as well, so that they're safe, right? But we want to keep their room free from clutter for all of our clients, but particularly for those with vision impairment. We want a clear path, nothing in their way. We can explain getting rid of throw rugs at home. That might help. During their meals, we can explain or tell them where things are on the plate with the position of a clock. We also want to encourage the use of glasses, obviously, if they have glasses, but maybe in magnifying glass, enlarge the reading. Everyone reads on iPads and computers now, so that's a lot easier than it used to be. For our clients with hearing impairments, they could be totally deaf or just hard of hearing. First, we want to assess for, cerumen or wax buildup. That could be an easy cause. And so maybe it's reversible by just having their ears cleaned out. If not, and they're just hard of hearing, or to encourage the use of hearing aids if they have them. And they're so small now that a lot of people didn't like to used to wear them, but we want to encourage that. When we're communicating with them, we want to face the client because some of them might read lips. We might use hand gestures as well. We want to minimize background noise, turn off the TV, music, and things like that. Maybe speak into the good ear if they have one. And again, we want to provide, just like we would for someone with another language, we want to provide a sign language interpreter if we need to, so that they can hear things in the language that they understand, and make decisions. Those with taste impairments, we don't always know about these people. They don't always tell us, and they think it's kind of normal with aging, and it might be based on disease process. But there's several things we can do. We want to encourage good oral hygiene and dental practice, keep the mouth clean, encourage them to season their food, again, based on their diet restrictions, of course. Offer different textures of food or stimulate their sense of smell, because that does go with the sense of taste. For our clients with speech impairments, whether aphasia from a stroke or brain injury or, neurological disease, and it could also be associated with a loss of hearing, right? We want to allow for extra time for them to respond, ask a question and wait, be patient with them. Don't interrupt or finish their sentences. We can use a picture board if needed, where they can point to things, or a whiteboard if written communication works. And then finally, for those with some sort of tactile impairment, we may provide touch therapy. Increasing the pressure of the hand when touching a client may help them feel more. We can turn and reposition those with sensory alterations in touch. And then finally, with those with neuropathy, if they've got, long-term diabetes or whatever, we want them to check their feet every day. We want them to wear closed-toed, well-fitting shoes to prevent injury. All right, quick overview of sensory function. Again, kind of goes with neuro. So videos posted in week 13. There's one on eye emergencies, kind of when we should encourage our clients to go to the emergency department. And then another one I thought was really interesting was visual and hearing impairments in children, because we talk about the lifespan in patho. Assignments to complete again this week. That accountability team, if you haven't met yet, go ahead and meet together. And then quiz 4. Have a wonderful week.